Hello, I'm Dr. Mark Gold, and on behalf of CME Outfitters, I'd like to welcome you and thank you for joining us today for our educational program. Our activity is titled Putting Pressure on Prescribing, Novel Approaches to Pain Management. This activity is brought to you by CME Outfitters, an award-winning, accredited provider of continuing education for clinicians across the globe. Also, today's program has been designed to meet the requirements of MOC and MIPS and improve your practice with respect to pain and your decision-making process around opioid prescribing or not. Your active participation in polling questions, we'd like you to do that. We'll put up a question and ask you to complete that. We also would like you to complete our evaluation and post-test, and that's the first step in the process. After today's program, incorporate the clinical improvements we discuss, and in 2 to 3 months, CME Outfitters will send you a survey to complete, which will fulfill the data collection requirement. You'll then receive a confirmation you can submit to CMS. It's that easy. Our goal of today's activity is to help you safely and effectively improve the lives of your patients in pain. As I mentioned, I'm Dr. Mark Gold. I'm an ASAM Annual Lifetime Achievement Award winner and currently adjunct professor at Washington University in St. Louis School of Medicine, Department of Psychiatry. I'm looking forward to today's program. I know all the speakers, and we all have worked very hard in one area or another of opioid research, practice, and policy. And I think we complement each other very well. Given the scope of the opioid crisis, affecting change takes this kind of collaboration across many healthcare disciplines, across government, industry, advocacy groups, and our panel reflects that concept. First, let me welcome William Alden. Bill spent 30 years with the DEA and is now the chairman of the DEA Educational Foundation. Welcome, Bill.
Thank you, Mark. Glad
you.
to be here.
Also, let me introduce to you my colleague, Stephen Stanos. Dr. Stanos is the medical director of the Swedish Health System, Pain Medicine and Related Services in Seattle, Washington, and the past president of the American Academy of Pain Medicine. Welcome, Stephen.
Thanks for having me.
Also joining us today via video is Jessica Hulsey-Nickel, who is the CEO and founder of Addiction Policy Forum. I interviewed Jessica earlier this morning, and we'll share that interview a little later in the program. Let's get started by reviewing our learning objectives. First, we're going to start with the patient, as we should, and talk about the importance of education. Educating patients about their pain and pain plan is a great first step. We'll also talk about management of pain in your patients with the goal of giving them and you new strategies, at least 2 that you can integrate into your practice immediately. Our second objective will be to cover pain management when opioids may be appropriate, and we'll discuss strategies, new strategies that you can integrate into your practice using non-opioid strategies. And finally, we're going to talk about addressing opioid use disorder. As part of my interview with Jessica Nickel, we highlighted some innovative programs from around the United States which you can implement yourself. Before we move into the opioid crisis, let's talk about how we got here. In the last month, HHS released a comprehensive plan on the current guidelines and need for improving pain management, and they confirm that pain is a biopsychosocial model. Let's start with the animation, Stephen. Can you tell us about Phil that we helped develop and show at the ACP for the first time?
Yeah, no, I'm excited. I think it's a great way to start a discussion about pain, addiction, and I think what we did with Phil here in this augmented reality, Phil, is the nice way to represent the human body and the complexities. If you think about our own sensory system, we do a good job of picking up and kind of observing what's going on in the environment. So normally it takes really a noxious stimulus to really sense the body that you're in pain. So we have nociceptors in our skin. Those nociceptors can respond to heat, chemicals, trauma, and they can help start this complex pathway that goes to the brain. But normally our bodies protect that. Our brain is constantly trying to decrease pain signals as well. When you have trauma, which can happen over time, there's trauma in the tissue, that sets off a whole cascade of changes, whether it's neurochemical or not. And so in this case, our patient here, say he has an injury to his arm. The nociceptors are activated. Those signals are transduced into electrical activity. That electrical activity is going from the conducted along the nerves to the spinal cord where it's transmitted to the brain. And at the brain, there's a whole complex set of reactions. And in some cases, that can cause an increase or decrease in pain. And so we have different types of pain. We have nociceptive pain, which would be from trauma, where those receptors are being activated. We have neuropathic pain, where the nerves are injured, like a stroke, or postherpetic neuralgia, like from shingles pain, where the nerve is hyperexcitable. And then we have a third type, which is central sensitization, where the nervous system is kind of upregulated. In many of our patients with chronic joint pain, let's say, even though the tissue pain goes away or the tissue stimulus, the nervous system is upregulated, what we call nociplastic pain. And so this is going to be important because the medicines we use, whether it's anti-inflammatories, opioids, antidepressants, those affect chemically to decrease pain signals, but then exercise, deep breathing, relaxation, steroid injections, those will also affect those pathways. And so I think that's just important, and especially when we talk about addiction, because those pathways in the brain are also kind of running amok in understanding pain, addiction, and that complexity.
It's really a nice demonstration, and I want to make sure the audience is aware that this animation, in addition to many other resources related to opioids and the neuroanatomy of pain that we'll be discussing today, will be available at CME Outfitters Opioid Education Hub, and you can find it on the web. We encourage you to look at that site. You can use the slides. You can even use the animations and videos in your practice and teaching and just engaging with patients.
And you bring up a good point. The animation in about a minute and a half shows those chemical changes, and I think in a nice, colorful way, so people can understand whether it's a patient or your colleagues about those complex pathways.
Yeah, it is only a minute and a half.
Correct.
Yeah, I agree. So let's shift quickly to the opioid crisis and overdose deaths. Here's a heat map of overdose deaths, and you can see that there are clusters that have been hit especially hard. The highest being Kentucky, Maryland, Maine, Ohio, Rhode Island, West Virginia in opioid deaths. Bill, let me shift to you in DEA's perspective. How did this drug epidemic get going like this in these odd concentrations at areas that we didn't see before? And what is DEA's perspective on this?
Well, this epidemic is so different than the past drug epidemics that we've been exposed to in the U.S., and I'm referring specifically to the drug epidemic that we suffered from 1979 through the 80s, through the crack epidemic in the mid-80s, and then onward toward the decline in the late 80s. And it's significantly different because, number one, it's so deadly. Mm-hmm. We didn't experience this in the past, number one. Number two, the users are completely different. In the epidemic that we were confronted with in 79 and through the 80s, we were focusing our prevention education efforts on adolescent prevention. And this cadre of users addicted are much older. And the difference is also, you're talking about legal drugs versus illegal drugs. In the previous epidemic, we were dealing primarily with, almost exclusively with illegal drugs: cocaine, heroin, marijuana, and methamphetamine, and hallucinogens. In this epidemic, we're dealing with illegally prescribed drugs, legal prescription drug, that seems to be the initial exposure to most of the individuals who become addicted.
And these deaths, I remember myself working in the Yale emergency department in the early 70s and giving naloxone, but I don't remember the number of people dying. We had a heroin epidemic at that time, and now where the deaths are mostly fentanyl. And how do you deal with all this fentanyl pipeline?
Exactly. That's the big difference. Is a substance that was initially used as a diluent to dilute heroin is now being primarily used as a drug itself, because it is a drug. Fentanyl. It's a synthetic opioid, but it's also being used as opposed to just being diluted in the heroin samples that are on the street, and that's a significant difference.
And the DEA used to be able to look at volume and catch large quantities, and fentanyl quantities are minuscule. Lethal dose is
absolutely
pinhead.
Yeah, that's part of the problem. Part of the problem is fentanyl,
illicit fentanyl.
Illicit fentanyl is being primarily produced in China, in Mexico, and we're beginning to see exposure in India also, and it's easily shipped to the United States, often through the mails, and oftentimes through Mexico primarily, and then it's smuggled into the U.S. Where it's being utilized. So the DEA strategy is to exert pressure at the source countries, working with their counterparts in China, in the DEA offices in China, mainland China. There's been some changes in regulation where the Chinese are now beginning to regulate pretty aggressively the production of fentanyl. And the next challenge is how do you raise the stakes? How do you make it more difficult for traffickers to smuggle fentanyl into the United States from Mexico?
Well, we can see when you look at the deaths that the change from heroin, like people, the first phase of the opioid epidemic was prescription misuse and abuse, and then heroin, and now fentanyl. The synthetic opioids, other than methadone, are the big change from 2013 and the dramatic change in deaths as a result. In Massachusetts, they looked at 962 opioid-related deaths in 2018, where a toxicology screen was available, and they found that 90% of them screened positive for illicit fentanyl. Again, the deaths, 90% is quite dramatic. If you go back to our slide here, we see the U.S. impact for opioid overdose deaths. Again, highest Kentucky, Maryland, Maine, Ohio, Rhode Island, West Virginia in 2017. And really, there's a difference between the deaths and where the highest prescription rates are. The highest opioid prescription rates are in different states. So this is an interesting map because there's some overlap as you get down on the list, some similarities between prescribed opioids and deaths, but not directly. There's not a direct correlation. And again, I'd suggest that we keep looking at the data, and the newest data, I mean, I saw it come out today, showed that for many, friends and family, not doctors, serve as a gateway to opioid misuse, meaning that the prescriptions may have been taken as prescribed and put in a medicine cabinet only to be shared or diverted in some way, and that becomes the root of early abuse and opioid use disorders. It's a good new data and very important in the Journal of Addictive Diseases, where all addiction medicine professionals read. So, Bill, from DEA's perspective, what do you think this tells us about diversion and what kinds of things the DEA can do to help us with this supply chain?
Well, DEA has a diversion control division which is responsible for the regulatory oversight of the 1.5 million registrants that are active throughout the country. And they're also responsible for the diversion of legitimate drugs, which would include some of the issues that we're confronting today. And what DEA will do, they'll work with their state counterparts and they'll monitor prescriptions across the board in states. And when they see a blip in prescriptions,
like this one here.
Yeah, like the one that is displayed on the chart. then they'll create an operation and begin to try to mobilize that particular blip that they see. And oftentimes it's a doctor that isn't seeing any patients. That's a doctor that's strictly into business because of greed to overprescribe. It could be a pharmacist and so forth. So this was an operation that took place. That's a picture in the slide of John Martin, the assistant administrator, the new assistant administrator for diversion control at DEA. John was the former special agent in charge of the San Francisco DEA office. He brings a new face, a new vision to DEA diversion control, one of openness, of interested in working with the so-called industry, including the manufacturers, the physicians, the PAs, the pharmacists, and others in the field. And he's in the process of trying to make it more open and more collegial relationship because it's all our problem.
It is. So let's jump to our first learning objective, which is to educate patients about their pain and to discuss safe and effective multimodal treatment plans. I want to get our audience involved here. You'll see a question on your screen. How do you feel you educate your patients about pain before you prescribe a medication for their pain? You see the options on your screen, so please take the time and vote now. Okay, Stephen, while they're voting, it's important to educate patients about pain. Could it also affect their outcomes?
Yeah, I think it's obviously important to educate patients, and now the sense is how do we take that to the next level? We educate patients about side effects, but also educating patients about the expectation. What do they expect from the pain medicine they're going to take? Is it going to drop their pain 2 points, which is pretty good for an outcome? It's not going to eliminate their pain. But also the education part on understanding the physiology, what's going on. We as clinicians underestimate what patients can learn. In most patients, once they understand the issues around their imaging report from their MRI, why depression and anxiety increase pain, those types of things, they need to understand that if they're going to benefit from those types of therapy. So education is going to be key, not just from risk stratifying and minimizing harm, but making the patients more active participants if they're really going to participate in a multidisciplinary program.
To get shared goals.
For sure. And every patient has different goals, but you have to have that education about the expectations first, and then you can, I think, you streamline a treatment specifically for that patient.
HHS and you too speak a lot about biopsychosocial, and I know you have a biopsychosocial focus in your own pain program.
Yes, and so the HHS task force report came out last month, and that's a really comprehensive review of what's happening, what we need to do. And we've been saying this a lot in the pain management field and in primary care, but pain needs to be really managed at a biopsychosocial level. The old thinking was biomedical, that you have tissue damage, the tissue damage goes away and your pain goes away. That may be good in a very small percentage of patients, but mostly with chronic pain, it's a biopsychosocial problem. There's 3 different areas. Biologically, whether it's the pain generator, their age, other traumas they've had, psychologically, depression, anxiety, coping, and then last, social, how it's affecting their life, their interactions with other people. And that's going to be important because you need to assess patients in those 3 domains and then develop your treatment plan in those 3 domains. And every patient would be different. Maybe one person would be more biologic and a little more psychological, and then throw in an issue with addiction, even more important. So biopsychosocial is going to be key, and we as clinicians have to start thinking that way.
That's great. It's really nice to hear you say that too. But pain isn't just about nociception or the actual injury, is it? It's more about the whole person.
Right, and we showed, just to introduce the Phil, our augmented reality patient, that complex pathway in the brain. Remember, the brain is an output of pain, but it doesn't it doesn't correlate always with the intensity of the stimulus. So you may have a small minor trauma, and some patients can have significant pain from that. And so the key is there's so many other factors, and those factors that can increase and decrease pain are depression, anxiety, catastrophic thinking about pain, maladaptive ideas. On the other side, distracting, other things like that can decrease pain. Genetics, all these different factors that go into that complex pain response. And so that's going to be important because, again, our treatments have to understand that. And then again, with addiction, those pathways are also going to be important. So, reward properties about drugs, a stimulus about drugs, and what you're familiar with in the addiction world. So the brain's important. We used to tell patients, you would say it's in your brain. They say, no, it's not in my head. It is, but we have to understand that's how we're going to be treating, kind of from a top down, then top up kind of
So it
phenomenon.
takes a lot of education.
Correct.
And by providers and everyone. So thank you, Steve. And I want to summarize some key points for this section. First, use resources to educate yourself, your care team, and the patients about the type of pain that there are. I mean, there's more than one type of pain, and multimodal ways of addressing pain. 2, to educate your patients about their pain, get shared goals and objectives before initiating treatment. So let's move on to objective number 2 and begin to talk about prescribing strategies that are safe and effective, and how we might match a patient and their kind of pain to the right treatment. That would be everyone's goal. So what are some basic tenets of this?
Well, I mentioned, Mark, the HHS Interagency Task Force report actually was published in the last month and actually goes over 5 different areas, and medications are just part of it. So opioids are within that first column we see here, but they not just opioids, but non-opioid medications, topical analgesics. The second group is restorative therapies, physical therapy, occupational therapy, interventional procedures, so spinal epidurals, spinal cord stimulation. Those types of interventions can be helpful. Behavioral health, which would be cognitive behavioral therapy, mindfulness, relaxation training, and then the complementary and integrative health. And so the key is all 5 of those can be used. You don't have to start and fail one to go to the next, but how do you use those together and then design that program based on what the patients need. And across those 5 different areas, risk assessing patients. And we're going to talk a little bit about risk assessing patients for opioid use disorder or opioid problems, but we risk assess for adverse effects to NSAIDs, to anticoagulants, all sorts of things. But we want to be risk assessing the patient across, and that's hopefully going to help, and that's also going to include integrating education with your patient.
It's a lot. It's more than just where does it hurt and how much, and take a pill.
Yeah, well, I think you just described maybe where people got in trouble with inappropriate pain management. It's definitely a lot more comprehensive than that.
Bill, when you were talking about the DEA, when they looked at those doctors and providers, did they even have a physical examination or chart, or is it just they were just writing prescriptions?
They were just writing prescriptions for the most part, because DEA is not in the business of targeting individual doctors that are trying to do the business the right way, trying to treat their patients. That's not the role of DEA, and that's not what the mission is, and that's not how they operate. At least under John Martin, that's not how they're going to be operating.
Well, that's good to know. Steve, can you tell us about risk assessment and where it fits in the overall care plan?
Yeah, so the risk assessment is key, and again, it's not just at the evaluation of the patient, but you use that risk assessment and continue to follow that patient, and sometimes redoing your risk assessment. So taking a good history, performing a good physical exam, and then we have different tools you can use, which are screening tools to assess for depression and anxiety, potential misuse. And then with that information, especially related to opioids, you can individually decide, is the patient low, medium, or high risk. And if they're a low-risk patient, maybe you would not need to do a urine screen as frequently as a patient that's high risk. Or a high-risk patient, you might watch them closer for depression and anxiety and misuse of meds early on. So we like to risk stratify patients so we can have a better idea of kind of providing care that's more specific to what the patients need. So the risk stratification is just a starting point, and then you follow up on that with subsequent visits.
Well, and that, what are the risk assessment tools? They mentioned tools. What are your favorites?
Well, I think commonly the GAD-7 is a good anxiety screening tool, PHQ-9 for depression. There's now pain catastrophizing tools that are being used.
What is the GAD-7?
So GAD-7 is anxiety and has 7 questions, a very quick couple seconds it takes a patient to fill out. We also have PEG, which is pain, enjoyment of life, and general activity. In our clinic, we use that as our kind of to look at pain, but also function and
so
how it's affecting their
life. The patients can just fill this out, and it's available for you when you come in.
And we include that in our medical record, and we can follow it over time. So when we're not just focusing on pain, that's the key, is what's the effect on function, which is hard to measure, but at least we have a tool. The opioid risk tool was developed to used to predict risk for aberrant behaviors. So it's not a tool to predict addiction, but it's a tool to show what's your risk for having aberrant behaviors, running out early, maybe developing an addiction problem. And it goes over 10 different questions that include your family history of substance abuse and personal history, because we know the genetic susceptibility there. It also looks at age, so you get points if you're from 16 to 45, because we know that's probably the higher level that reports an addiction problem. A history of pre-adolescent sexual abuse. There's been a lot of work showing, especially in women who would report this more than men, that that type of trauma on the nervous system can also upregulate your nervous system and may contribute to risk for addiction.
So would that be a surprise for a patient to come in for pain evaluation or to a pain clinic and have someone ask about their physical, sexual, or emotional abuse?
I think our patients are more open to talking about depression and anxiety and now abuse, and they're hearing more about post-traumatic stress disorder and things like that. So I think it's in the public domain. But I'm always amazed at patients that check this off, and it's the first time anyone's even asked them about that. And that may be significant history that we would have never gotten out. So really the opioid risk tool is really a good social history. And again, it's one tool you can use to risk stratify your patients.
Stephen, I admire the assessment tools, and I think they sound very reasonable, but realistically, how many of your colleagues are using them?
Well, we're hoping that's changing, because I think with best practices around opioid prescribing, a lot of those incorporate assessing patients for these types of risks. So I think we're seeing an increase in that. I know in my own state of Washington, it's actually mandated that you have to look at risk for misuse, and you have to use some type of a tool to assess for risk. So I think over time, even at the primary care level and not just at the specialty level, this has become standard practice. And we're going to talk about the CDC guideline. It explains the importance of assessing for risk. So I think it was uncommon in the past, Bill, but I think now we're going to see more of that. It may vary from state to state.
I agree, and I think you'll see some changes too in the sexual and emotional and physical trauma data for males. This was an older scale,
yes,
and there was much more stigma associated with men talking about these things, but in some of the military experiences and recent experiences, people have been reporting it across genders.
Yeah, you bring up a good point, and we've learned a lot from the VA and DOD system, who had to deal with the opioid epidemic and crisis many years ago and kind of poorly managed chronic pain. And they've really done a ton of work on looking at suicide risks, overdose risk, and actually putting together step care models to really help do more comprehensive pain care.
That may be one of the things that is very similar to the previous epidemic that I talked about in the late 70s and through the 80s.
Vietnam.
It was exposed, the military. We learned a lot from the early military exposure back then also.
And there was a lot of trauma.
Lots.
Yeah. You know, it's important to keep that in mind, and I really applaud your efforts here in HHS to think about that. So what's the role of these risk assessment tools, and how do you then use them to individualize treatment?
Yeah, I think that the risk assessment tools are, they're mostly based on self-report, so you have to take that at face value. Use those tools, but also have a really good discussion, and I think what HHS talked about was developing a really good therapeutic relationship. I mean, you really need to have that interaction with the patient. They can trust you that you can get the right type of information. And so when a patient does develop a problem, they're able to tell you what's happening, and then you can shift their treatment. Do they need to work with a psychologist? Do they need some type of other intervention? So again, with individualized patient care, the tools are used. Some tools you could use at the assessment, but we can use tools on an ongoing basis to screen for depression and anxiety, misuse of medicines. And again, the key is going to be getting those worked into your workflows and making it easy, getting into the electronic medical record. So those are some of the barriers that we're all kind of working on.
It's really helpful even for HHS to consider some of the alternative therapies, which they are. I mean, yoga's on the list.
Yeah, and I think the other part too is what HHS and other groups have been saying is that payers need to start covering these types of treatments and to actually support multidisciplinary care into collaborative care, whereas now it's not reimbursed, there's no coverage for that. And so
behavioral health especially.
Yeah.
People talk about anxiety, depression, and trauma, and it's hard to treat a person that has an active comorbid state like that.
Yeah, and even patients with opioid use disorder, they may get approval for buprenorphine, but to get approval for psychological counseling, is still not covered well.
So in 2016, as you said, the CDC came out with the guidelines for prescribing opioids for chronic pain. Can you walk us through these?
Yeah, so this is an overview of the 12 recommendations. The 12 recommendations, this was published in 2016, like you said, Mark. It covered 3 areas. First, determining the need for opioids, so who's appropriate. The second group was opioid selection, dosage, and the duration of therapy. And the third part, which was important, was assessing risk, like we talked about, and addressing harm and what to do about that. The recommendations, which I'll kind of overview here, they definitely in the first recommendation state that you should use a multidisciplinary approach, that opioids aren't first line, and if they are to be used, they should be used with other medications and other interventions, which I think sounds pretty straightforward, but a lot of clinicians weren't doing that. Establish and measure function and goals like we talked about, not just pain. They also talked about discussing risks and benefits of therapy, so again, education is going to be key. Where there was some controversy was around the prescribing, and this was set up for new starts, not patients already on opioids. So for new patients, they talk about avoiding going over 50 morphine equivalents, and if you're going to go over 90, you really need to justify the clinical benefit. And the whole goal of this is to try to prevent patients that don't really need to be on opioids for prolonged periods of time or at higher doses, because we know those higher doses may put them at higher risk and other issues. So this was for new starts. Unfortunately, there was some confusion around that. The recommendations also talked about within the text, if you inherit a person on chronic opioids, to try to decrease the dose. But to do it in an empathetic and compassionate way. And so the rest of the recommendations talk about trying to limit short-acting medicines, use of for acute pain. So if there is an acute pain condition, we're talking about this, maybe 3 days or 5 days of a supply for an acute injury. You don't need to give someone 30-day supply to really be cautious with that. And then they walk through talking about checking the PMP, which is our prescription monitoring programs, which most states have now, doing urine screens, prescribing naloxone to prevent overdose deaths in patients that are at high risk, and then having access to opioid use disorder treatment, which again has been a problem for many clinicians. So those were the 12 recommendations that came out in 2016, and now there's
in April
been some...
they had the guidelines. The authors themselves wrote this New England Journal of Medicine piece.
Yeah, and so there's been a number of groups, pain society groups and advocates that were seeing that patients were being wrongly discontinued off their medicines. There were some state legislatures that were putting together recommendations that were saying they were from the CDC, but did not really clearly represent what the guidelines said. And so the authors of the guideline came out with a perspective in JAMA and talked about the misinterpretation, the misuse of these. And because of that, we saw harm to patients. There was an increase in suicides and patients being abandoned. And so I think now the pendulum has come back to the middle to try to figure out who's appropriate for opioids, who's not, how do you do this in a rational way, and then how do you prevent some of the harms that opioids have caused.
That's good. Thanks. Earlier in May, the Department of HHS, their task force, shared their best practices. What were some of the big picture items? What are the big takeaway that you took from this HHS report?
Well, I think the first part was they did explain that we need to do multidisciplinary treatment and we need to incentivize that, not just for pain clinics, but at the primary care level, and to really look at treating pain like other diseases, like diabetes and HIV, where there's a collaborative model that's been proposed and used in the primary care level. They talked a lot about education, as well as increasing research and understanding that complexity between addiction and pain. So again, I think it was a good report to really show some of the gaps that are out there and then where we need to go. But the key is that it really focused on multidisciplinary, multimodal, in really kind of being careful about using opioids for those patients that need it and help those patients that are having problems.
That's very helpful. Bill, can you tell us a little bit about the DEA drug diversion conferences and education conferences for physicians?
Yeah, DEA last year started a program called PDAC, the Physician Drug Awareness Conference. It's a one-day conference that they're holding. The goal is to hold it in all 50 states over the next few years.
How many have they done?
They've done 9 states so far. And what they do to announce their presence and to invite participants, they will send an email blast to all the registrants.
That means anybody has a DEA license?
Anybody who has a DEA license in that state will get an email blast saying that DEA will be conducting a full-day seminar 2 days in a row at a given site, and here's how you register. And to find out information about that, you can use their website, deadiversion.usdoj.gov.
That's up on the screen.
Also,
what would they expect to learn there?
Well, what it begins to do, it announces right at the beginning that DEA is taking a collaborative mode. They want to work with the discipline and they want to share information. They want to do the best they can to inform the discipline that they have a responsibility to follow the regulations. And if they follow the regulations, there are no consequences. So to begin with, and it's a discussion similar to what we're having here. DEA diversion control is working with HHS to form this collegial relationship and inviting them to participate. So it's a new approach, quite frankly, at DEA, and it's a healthy approach, and it's one that's long overdue.
Well, that's really helpful. Thank you. Stephen, there are non-opioid treatments that we can give in pain management and acute pain. Are they effective?
Yeah, and I'm glad we brought this up. We have an interesting study here. The question is, we can use opioids, which have a certain route to affect analgesia, but we can also use non-opioids. And there's been a number of studies showing using an opioid with a non-opioid or multiple non-opioid medications, there's synergy between those two drugs. And this study here was from various Cochrane reviews that they looked at and found that the number needed to treat, and this was in post-operative pain studies, the number needed to treat, which is the number of patients needed to get a 50% reduction in pain, was pretty high for just oxycodone by itself, 4.6. But when they used oxycodone at lower doses with acetaminophen, it actually was a better number needed to treat. And they saw similar in some studies looking at NSAIDs versus NSAIDs used with acetaminophen. So I think the whole idea is here is being more rational, and multimodal can imply using multiple meds together to get that analgesic response. And like I showed in our figure with Phil, there's really complex changes in the nervous system, so different mechanisms need to be attacked with medicines as well as the non-pharmacologic treatments.
Does that apply to surgical procedures too?
Yeah, and for sure, because we know with surgery there's significant trauma to tissue, but most surgical procedures within a couple of days, patients should have minimal to no pain. This study just actually came out. This is from a group in Michigan that's done a lot of this work with safer prescribing in the perioperative period. They actually looked at patients that were going to go to elective surgery, and there were 6 different surgeries: inguinal hernia, laparoscopic surgery for cholecystectomy, and prostatectomy, some common procedures. And those patients agreed not to use opioids post-operatively, and they put them on scheduled acetaminophen 650 milligrams and ibuprofen 600 milligrams, and they took that every 6 hours. They were given very small amount of breakthrough pain medicine, from 4 to 10 pills, depending on the type of surgery, and they're only to use that if they had severe pain. They went back 2 or 3 months later and looked at patients and asked them about their response. Over 50% of patients used none of the opioids for breakthrough pain.
That would have really surprised.
Yeah, but if you think about a lot of our surgical procedures, patients maybe have pain for 2 or 3 days. And in this case, they reported good pain scores. There was maybe 1 or 2 patients, I think, that asked for a refill. And then also it told us that you can use a lot less medicine. Most patients are commonly given 30 to 60 pills to go home. They're prescribed more out of convenience, so the physician won't get called. And that led to a lot of these unused meds that we were talking about. So it also helped to clarify that you can give a small amount of meds, and many times those meds aren't going to be used, or they just need a short supply. So I think the key here was that in this case, non-opioids, in most of these patients, they were able to control their pain, and then that prevented patients developing chronic pain. Because remember, many patients undergo surgeries in this country. Close to 10% that were on opioids before end up needing opioids. Now, I'm not saying some of those patients didn't have a need for that specific regimen, but a lot of our patients maybe unnecessarily get placed on opioids and never taken off. So I think this is a good way to prevent overuse and prolonged use, which again I think has caused a lot of problems for certain patients, as well as issues around diversion.
I really like this study, and I find it useful for patient education and doctor education as well.
Yeah, and it underscores the importance of multimodal treatment and really doing a good job. And they really had a structured program, and a lot of hospitals are taking that on. And the CDC is looking at that, as well as how do we develop better guidelines on perioperative pain management, whether it includes opioids or not, and how to do a better job with that.
So when we were working on our educational plans, and we had an expert from the University of South Florida, Dr. Hassan Mir, and he was part of our team and helped us think about pain and non-opioid medications, and he was part of the orthopedic surgery guidelines related to trauma and what kinds of approaches we could take to reduce opioid exposure and use other treatments. What do you think about them?
Yeah, so this is an example. They broke this down, his group that looked at treatment guidelines for perioperative pain. And this is for major surgery. And they broke it down to what to use opioids and non-opioids in the inpatient setting, and then each week 1, week 2, week 3. And so over time, even if they needed an opioid, they were given small amounts In the perioperative period, they were given oxycodone with acetaminophen, maybe hydromorphone IV if they needed that, but they were also given ketorolac, scheduled NSAIDs, as well as gabapentin. And I think what's nice here is that it kind of walks clinicians through. They're not encouraging overprescribing of opioids, and it gives, I think, physicians an understanding that this can be done in true multimodal. What we see here is multimodal.
It's not a 4 or 5 week plan. It's
yeah,
rather
within a
than
couple
1
weeks they're
minute.
not on any medicines versus give a patient a script and kind of guess to see what happens. So this was just for major surgical procedures. I think the next slide highlights for minor procedures, and obviously there's probably less of a need for stronger opioids in shorter duration. But the same idea, hydrocodone or oxycodone with acetaminophen for the opioid, consider tramadol, which is a weaker opioid, and then on the non-opioid side, scheduled NSAIDs, acetaminophen, gabapentin, again, a multimodal approach in giving patients that schedule versus kind of shooting in the air and hoping that patients will do better.
And the non-operative.
Yeah, and then this third group looked at just for trauma, for minor injury and major injury, with a lot of patients that have injuries that they recover from, but how do you get them through that short time? But at the same time, give them good pain relief, but not overprescribed medicines. And so here, for minor injuries, considering using tramadol and NSAIDs again, and for maybe major injuries like a fracture, hydrocodone or acetaminophen, but smaller doses, shorter duration of time, and closer monitoring.
Well, this was a lot to digest, and for the people who are watching us and have these slides, you can get the full guidelines on the Opioid Hub at cmeoutfitters.com. So thanks, Stephen. One thing that I took away from Dr. Mears' comments was that he actually writes a prescription for acetaminophen or ibuprofen or both with directions, and he thinks giving the prescription helps all by itself.
Well, I mean, there's always the question about the power of your pen and that prescription to hand a patient, and does that help the placebo response, that expectation about pain relief? I think when you're writing a script, the patient feels that you're putting the time
They feel
into
like
it.
it's a real treatment. They think it's a real treatment.
But I think the key is that he spent time with them and he educated them and he gave instructions. I think the key, especially with the over-the-counter prescriptions that you write scripts for, you can do it on a scheduled basis, and I think they realize the importance of that. A lot of patients just think because it's over-the-counter, it's not effective or it's less effective, and so they may add power to that. But I think the key is really expectations. They understand why they're getting an NSAID, why they're getting acetaminophen, why they're getting the opioid, how that works together, and then what their expectation is. How much pain relief are they going to get?
Yeah. Well, we spent a lot of time thinking about opioids, and the first part of the opioid epidemic was prescribing opioids, and then we talk about opioids being in people's medicine cabinets and around, and there's a risk of just having them. And then the new data today that's the way that many people get started in an opioid use disorder. Bill, what can we do once we have an opioid prescription? We take the medicine as prescribed and we're left with medicine. What do we do? What do you suggest?
Well, one of the things that we do whenever we do our opioid awareness presentation is, and we call it Understanding the Opioid Epidemic, a call to action. The action is going home immediately, going through your medicine cabinet and disposing of the prescription drugs that you're no longer using and disposing of them in a safe and environmental way. And there are a lot of products on the market today that provide the ability to dispose of your prescription drugs at home rather than having to go someplace for a take-back. DEA has a semi-annual program called National Take-Back. They promote it, it's promoted, they have a media buy that they do, and each year there are tons and tons of prescription drugs that are turned in that are ultimately destroyed by DEA and incinerated. But it's much easier, I believe, to do it at home yourself, because then you don't have to take an action to go somewhere. So I believe there are a lot of
Have you ever done that
yes,
yourself?
I have. Yes, I have. I recently moved, sold our house in Virginia and moved to Florida.
Good state.
Yeah, moved to Naples, Florida. And when we were moving, my wife discovered a whole bunch of prescriptions that we had that were old that we hadn't used and that I hadn't bothered taking down to the DEA office.
You work for the DEA.
For take-back. Right,
Yeah,
exactly.
Yeah, he worked for the DEA.
Because it was, I had to take action.
Yep.
And what I had was I had a couple of the tear pouches that were available that I utilized, and it was very simple. I opened them up, put the prescription drugs in, added water, sealed it, shook it up, threw it in the trash. Environmentally safe, deactivates totally the active ingredient in the drug.
Well, that's, the net is we want to get rid of them because it's like a drug supply in your own house.
Right. Absolutely.
The FDA said throw it down the toilet. What do you say?
Well, that's controversial. I think there's a couple things you can tell patients. So, we tell patients you can mix in like coffee grounds or kitty litter in a plastic bag and throw it in the trash, and that hopefully would not get in the hands of someone that has a substance abuse problem. The FDA does say you should flush certain drugs because there's the higher risk some perceive of keeping a medicine in the cabinet versus accidental exposure. I mean, we're forgetting if a young child or an animal gets a hold of a pill and takes it, they can have respiratory depression and die as well. So that's controversial. I mean, the other thing, similar to what Bill was talking about, there are takebackmymeds.com and other websites that are similar. Patients enter their name or their zip code, and there's actual takebacks at pharmacies that are cooperating, police stations, so on an ongoing basis. Part of our after visit summary, when we see patients in our clinic and like a lot of hospitals now, we are by law have to give recommendations on disposal of medicines. Our hospital system has receptacles on our campuses that patients can return meds. So I think in the last 2 years there's been a huge increase in not just the twice a year take-back programs, but having sites and pharmacies that are able to take unused meds back, as well as hospitals and clinics.
Well, we appreciate those pharmacies and retail pharmacies stepping up. There are a lot of important roles for retail pharmacies and pharmacists. I mean, we don't want to stigmatize people with pain. Somebody who has an opioid prescription goes to fill it. We don't want them to feel
a second-class citizen.
Scarlet letter, and that's really important. Is there any advice you have there?
Yeah, I think for patients, and we talked about education. I mean, pharmacists are starting to understand better the complexities of the chronic pain issues. Patients are understanding some of the monitoring we need to do, and we don't want to stigmatize them. And even on the patients with opioid use disorder, that they have a disease, it needs to be treated. So I think stigma's been a big issue, but it takes really kind of a collaborative approach in education with all the different people, the pharmacist, the physician, the DEA, all those different groups. To really help patients, and because stigma again has been really a barrier for some patients.
But if we can prevent one of the famous adolescent pharma parties, where adolescents dip into their medicine cabinets, their parents or grandparents or relatives or guardians' medicine cabinet, and they fill up their pockets and then they take it to a party and they drop it in the bowl, and then during the evening they all reach in and start taking them. If we can avoid that by the proper disposal, obviously that's the best way to proceed.
And I think too that the data came out in the last year from some of SAMHSA that we have seen a reduction in adolescents misusing medicines other than for medical reasons, and hopefully that's a good sign that there's less of a supply out there and it's having an impact.
Good. So let's shift gears for a second and go to learning objective number 3, how to integrate and practice concepts for novel programs in the community. What are they? What are these novel programs to help us with opioid overdose and opioid use disorder? I talked earlier today to Jessica Nickel and want to share what she said about this important topic. I'm here with Jessica Hulsey Nickel, founder of the Addiction Policy Forum here in Washington, D.C. Welcome, Jessica.
Thanks so much for having me.
Jessica, for those in the audience who are not familiar with Addiction Policy Forum, you or your work, can you give us a brief overview of the organization?
Yeah, absolutely. We started about 5 years ago, and we really wanted to bring everyone together to one table. Patients and families, physicians, providers, researchers, scientists, all the key stakeholders to tackle this issue in a different way and really build a patient advocacy group. We also really believe in translating the science. Too many people understand this as a moral failing or a character flaw and not a health condition. And one of the best ways and easiest ways we can tackle that is to bridge that gap between what we know from research and science and how we talk about this to families, patients, to the public, and other stakeholder groups. So we really work closely to try to do that.
When you thought about this and doing this, is there a reason that you chose addiction rather than diabetes or cancer as a life mission?
Absolutely. I've been doing this work since I was 15, which is more years ago than I'm going to admit. And I lost both my parents to heroin use disorder. So I got involved in prevention first, and then a lot of policy. And this is a disease that hit my family when I was very young. Addiction when I was a child meant homelessness and foster care, and then I was raised by my maternal grandparents. My mom did find a little, several years in recovery, which was a gift, and my dad unfortunately never did, and I lost both of them way too soon. My dad was 48 and my mom was 50.
So that gives you a lot of motivation to make a difference in this area.
Yeah, it's our fire in our belly.
Thanks for sharing that, and I'm sorry about it, of course.
Thank you.
Wish that we could help people, and I guess you and your organization are trying to do just that.
Yeah, we are. When a disease strikes, it can feel a little bit like you're drowning and you don't know where to turn for help. And there's far too many people who can take advantage of families and patients who are vulnerable. And at the end of the day, we need people to find doctors. We need them to find physicians like you and a real plan and a treatment plan, and not be taken advantage of. So that work is important to us. So many of us at Addiction Policy Forum, we've been there firsthand, and we really want to sort of change what this whole experience is like when it does hit your family.
Thanks. Your work has focused a lot on addiction as being a brain disease. Mm-hmm. So is mine, from different points of view. But you're a great ally in that work and trying to get the word out. But there's a lot of resistance to that thought and the concept among health providers and people in policy. Have you made any progress there?
I think we have. We've tried to sort of take the science, and brain science is complicated, and particularly if you're a family member, you're in crisis when you're usually seeking information. So learning is a little trickier when you're in crisis. You're sort of, our typical time when we're helping people and we find folks are in the middle of the night on a Sunday or Monday. So something just happened that weekend, and then you have a worried mom or dad who's on the keyboard and searching for help and answers. So we really try to take the science and boil it down to little snack packs that you can consume in one sitting. And we really need to work with researchers and scientists, physicians, providers, the experts to teach us, so then we can teach others. And not just patients and families, but also whether it's folks in healthcare, because we need to make sure that we're nuancing this. It's criminal justice stakeholders, educators, teachers, principals, school counselors. There's a lot of folks that need to understand this information. And what we've discovered in some of our testing of the brain science pieces is that when you're teaching how this affects the body, how it affects the brain, you're secretly building empathy and compassion. So you understand why there's changed behaviors, why there's changed priorities. We don't always have the most well-behaved patient population, and there's a reason for that, and that's built into how it affects the brain. And so if we take the time to meet people where they are, not just our patients, but every stakeholder group that has contact with folks who are struggling with this disease, you could really see a change on how we interact with them.
It's not only your work in educating the public and policymakers about addiction being a brain disease and what we can do about it, but you've been thinking a lot about raising the bottom. There used to be a notion, I kind of go back in the field to the early 70s, that you had to wait for somebody to hit bottom.
Yeah.
How are you trying to change that?
So we have a video explainer, an animated explainer series that takes some of whether it's the brain science or explaining severity and levels of severity, or this notion of rock bottom and other myths that we have when it comes to the disease of addiction. And rock bottom, so much of this comes from a really easy thing for us to point to when we are just feeling very uncomfortable about discussing someone's alcohol or substance use. It's uncomfortable. I work in this field, and I find it uncomfortable to talk to a girlfriend or a colleague or a peer about their alcohol use or their marijuana use or any sort of drug use. It's uncomfortable and it's awkward, and you don't know how to start. And we have these, it's not my business, or wait for it to run its course, wait for their rock bottom, something's going to happen. But the reality is, addiction gets worse over time, like most other health conditions. So waiting for it to get worse, to sort of get more severe, to have more consequences, not just physically, but also employment on personal relationships, whether it's your family system or your friend system, your support network that you need. The longer we wait to engage, the harder it can be, and sometimes the more difficulty on the recovery process. So we try to teach people about like using their levers. So if you think about a person who's struggling with this disease, and so many folks that we work with, they talk about the cop or the judge that engaged with them, and they kind of pulled the lever. They sort of gave them that reason, or sort of that the carrot and stick approach to figure out a new path and to give them some options. But there's so many more levers that usually we come in contact with before we are arrested or lose a job or have something of serious consequence be our rock bottom. It's a failed relationship. You're in trouble with your spouse, your boyfriend, your girlfriend. You've gotten in trouble at school. Your parents want to engage. So if we do a better job of teaching people how to use their levers and engage with that person in a kind and loving way to say, I'm worried about you. Can we talk about your drinking? Can we talk about your drug use? I'm here to get you help. And we teach people to approach it that way. We can see a process of intervening sooner and having better health outcomes.
You know, we did a lot of work in the area of physician health and physician addictions, and we had to do that. And actually in my group, Lisa Merlo, a researcher, showed that physicians who were coerced or helped into treatment early did just as well, if not better, than those who came to treatment after an accident or after an infectious disease or after some tragedy at work. So there's evidence on the side of your idea of lifting the bottom. There's not much evidence on the side of waiting till someone gets hepatitis C or HIV.
Or an overdose.
You think about the overdose data. I mean, the average person is overdosed multiple times.
Absolutely.
You think one would be enough.
And I think with sort of a fentanyl in the mix, the risk for a fatality is so high that I think we just really need to tackle some of our outdated preconceived notions like rock bottom, and teach people. And it's employers. I love the Physicians Health Program, and I think employers can play such an important role. Because losing your job or having difficulties in your job is one of the first indicators of a worsening substance use disorder. So giving your manager, your boss, the companies, folks that employ individuals, the lever and the training to use that better could really sort of arrest this disease, stop it in its place before it worsens.
So there's a new paper that came out about people with opioid use disorder and how if they have Medicaid coverage or no coverage, they can't really find help very well. And did you see that paper?
I did. It's worrisome. We know that we have significant barriers to accessing medication-assisted treatment. And the fact that the type of coverage that you have or having no insurance or ability to pay can really, further limit. We know this and we're hearing this on the ground, but it's very concerning because the costs are high. When someone is reaching out needing MAT for an opioid use disorder, the stakes are very high, and any barriers or difficulties that we're throwing in their way to accessing care, to finding a physician to help them manage this very serious health condition, is putting lives at stake and families really vulnerable. So we're very concerned about it.
Yeah, no, I think it surprised people because we thought we'd made so much progress in the number of providers, the number of prescribers, the number of waivers granted. But if you ask people who have a waiver and who do provide buprenorphine, for example, if you're a patient with Medicaid or no insurance, they may not be available for you even though they have slots.
Yeah, it's very true. I think that we know that for our communities, our patients and families, that come from don't have a lot of economic means, we see vastly different recovery outcomes. So we have a disparity on what's available to folks based on sort of what community they come from, and tackling that is really important.
So thank you, Jessica. If we don't address this issue, things only are going to continue. The recent study by Allison Pitt at Stanford using artificial intelligence said we could expect another 510,000 deaths if we do nothing. No single policy change would cause a significant reduction, and we need all the responses possible. Of those, the one with the greatest potential impact would be wider availability of naloxone, which would reduce deaths by at least 21,000 over the next 10 years, widespread MAT availability, and then, as we described, some change in prescribers. This was a theory, an artificial intelligence theory, but more recently it's even been shown in new data where in the state of Colorado, naloxone, by being made available, as predicted by the Stanford study, has actually decreased overdose deaths by 6.4%. So naloxone is one idea, and very important idea, that we should consider. I mean, Jessica had some thoughts about novel treatments too, not only widespread implementation of naloxone or MATs, but how to deliver that. What did she have to say about treatment programs around the United States that are worth emulating? Addiction Policy Forum has an award program called Innovation Now that recognizes novel addiction programs in the community, and the idea being that they can be models for others. One of your Innovation Now awardees is my friend and colleague, Dr. Jim Berry, whose COAT program was featured here, right here, by CME Outfitters in a webcast in October.
That's great.
And the feedback that the doctors that watched him gave us was tremendous. Many of them saying that his model program and the ingredients of that program were so well stated and articulated in this presentation that they could just adopt it just after listening to him.
Oh, that's
so
great.
So I wanted to know what other programs you might have, other examples of programs that you've recognized that are novel and impactful and that would be of interest to the people watching us.
Yeah, absolutely. Well, we love the COAT program and Dr. Berry's work. He's quite a leader in this field and an inspiration. A few of the programs in the healthcare lane that I think are truly innovative and we would love to see replicated and scaled up. One is Aware Recovery Care. We know that there is lots of different difficulties with barriers to accessing treatment, and a big one is if you're in a rural community, if you don't have enough providers, if you don't have access to transportation, it can be really tricky. So it started in Connecticut and has expanded from there, but Aware Recovery Care takes the visiting home nurse model and applies that to treating substance use disorders. So they don't have one sort of brick and mortar place where you have to sort of come to one center and it's in one community and a state. They send the nurses out, and the nurses are sort of the hub of an entire team, a multidisciplinary team that works with the entire family, including a marriage and family counselor, MAT access if you have an opioid use disorder or an alcohol use disorder, and all these other components that the family needs. Addiction is a family disease, and so having the interventions and the support to all the different members of the family that are impacted by the illness is super effective. The results from this in terms of retention and recovery rates among patients is really impressive, and I love how they've approached this, and they've used another model that we've seen in sort of high-risk OBGYN patient groups that we've used home visitation and then applied it to another high-risk population with great results. And the other two that I really love, we know that if you've had an opioid use or an opioid overdose, that you have a greater a chance of having another one and a fatality. But there's been very different types of interventions or lack of interventions that we see in emergency departments. And there's lots of I think, gaps in the services and resources that we've provided to the ED. So the Mosaic group in Baltimore sort of came up with a solution, and they've implemented it in over 11 hospital systems in Baltimore. So they begin buprenorphine treatment on the same day of an overdose or someone being screened for an opioid use disorder, and then they have a hot handoff to a provider that they've already linked up to the very next morning or even the same day. They have a recovery coach that is deployed to the emergency department to work with that person, and if the patient elects not to engage in treatment that day, they follow up with them for 90 days, and we see interest and engagement that happens as a result of that follow-up care. And the last one that I really love is Moms in Recovery, which comes out of Dartmouth. They were doing looking at prenatal care and prenatal visits for pregnant moms who were also undergoing treatment for opioid use disorder, and they were seeing a lot of appointments being missed for prenatal care. And then after talking to their patients, they realized there were so many different places you had to go to. I have to all these prenatal visits here. I have to go to the opioid treatment program for my medication here, and they brought it together, Dr. Julie Frew, in one place. And have even added extra services, like you can get diapers, and there's a food pantry, and there's like a support network that really exists, and recovery support for these moms. And I love how they sort of tackled. I think they started with 5 moms that were initially providing services, and it has expanded greatly, and lots of compassion and care, and really meeting patients where they are, so you can see those recovery milestones met.
That's great.
Yeah.
Thanks for reviewing them for us, and
Yeah.
I'll look for them. Can I find them on your website?
Yep, we have overviews of all of our Innovation Now award winners, over 56 programs so far we've identified, and it's at addictionpolicy.org.
Thanks. Well, thank you for coming in. I know how busy you are, and
Thanks for having me.
Thank you, Jessica. Well, the purpose of this program isn't to spend a great deal of time talking about opioid use disorder and the treatment of opioid use disorder. It's important to just remind everyone that we do have some FDA-approved treatments for opioid use disorder. They're summarized on this slide: methadone, buprenorphine, naloxone, and naltrexone. It's important to keep in mind that all of the opioid overdoses are not accidental. Some opioid overdoses are actually as a result of suicidal ideation and planned, and some are passive suicidal behavior that psychiatrists are used to, kind of like Russian roulette. Or at Washington University in St. Louis, one of my mentees did an emergency department study where he looked at people who were rescued with naloxone and asked them about suicidal thinking. Did they wish that they were dead? Did they wish that they weren't resuscitated? Did they wish they weren't rescued? Did they think maybe people would be better if they were dead, and so forth and so on? And when you go through a real formal suicidal thinking evaluation, you do find greater numbers. And that's in a recent piece by the director of the National Institute of Drug Abuse, Nora Volkow, and the chairman of the University of Pennsylvania Psychiatry Department, Akendo. And they summarize the evidence. And there's other evidence accumulating in the field looking at suicide and how important that comorbidity is to overdose, especially repeat overdose.
Yeah, and I mean, you bring up a good point. Even for patients with pain, there many times we look at depression and anxiety and risk for addiction, but we forget that they are also at higher risk, significantly higher risk for suicidal ideation and plan. And there's some recent VA studies that showed that too. The number of those, a good percentage of those patients that overdosed, there was a suicide or they had suicide attempts in the past. So physicians have to be screening for that, and clinicians, because patients can just say, I don't want to live anymore because the pain's so bad, but over time that may just be go beyond being a fleeting thought, and they may take action.
No, I agree. There's more and more interest in this area as people realize that there are multiple overdoses, and that there have been interventions in between, and good handoffs. and still the same person is overdosing. Multiple.
And other medicines that they're on, benzodiazepines and alcohol. I mean, we forget about that with overdoses and how that impacts respiratory depression in patients overdosing, whether it be a suicide attempt or just an overdose from misusing their meds.
It's just important to keep in mind. Bill and Stephen, relations between the DEA and healthcare providers hasn't always been great, to say the least. Is there an opportunity to change this and change the attitude that providers and clinicians have about the DEA? What do you think?
Absolutely. As I think I said to you earlier, this isn't the first time DEA has been accused of being heavy-handed. They're accustomed to that. But I think what we're doing today, the cross-discipline collaboration, is really the key to having a significant reduction in the impact of opioids. And I think DEA realizes that, and they're very open and willing to be collaborative. I think with John Martin as the Assistant Administrator for Diversion Control, I think you're going to see a significant change and an openness on DEA's part, and I think it's long overdue. I think that's something that I was exposed to when I was at DEA, when Gene Hayslip headed the Diversion Control Division, and for some reason over time it disappeared for a short period of time. But I think it's back, and I think it's very progressive, and I think it's the way to go.
I agree, and I'm glad you made a good point that the collaborative approach with the different groups. I think the other area too is medical hospital associations, physician groups, physicians working with their state medical boards. There's that similar disconnect between the medical boards going after doctors, but they, in our own state of Washington, we've done a lot redoing the pain rules for the state, and what I've learned from that is those legislators and board directors need to understand pain and addiction, and once they start understanding, they understand the complexities of it, and I think we'll be more kind of getting the pendulum in the middle to do more appropriate care. So the state medical boards, the DEA, the physicians, the nursing groups, the pharmacies, all those groups need to communicate. I think we learn backwards, unfortunately, but I'm optimistic from what you said that the DEA is different. This is important.
Well, thank you both. Let's wrap up with our SMART goals: specific, measurable, attainable, relevant, and timely. So, Stephen, what are the takeaways from today's program that our audience should consider implementing in their practice?
Well, we talked about a number of times. It's a biopsychosocial approach with your assessment and treatment, and then that'll help you individualize your treatment planning to get a really patient-centered approach, whether it's using interventions, medications, psychology, physical therapy, injections, really doing a biopsychosocial assessment. You can use screening tools. We talked about the GAD-7, PHQ-9 for depression and anxiety, but also for screening for risk for misuse of medicines like the opioid risk tool. Educating patients, again, about the expectations about pain, educating them about their pain condition so they can understand that better. Those are all going to be key, and I think educating all the different stakeholders involved. I mean, it sounds like this is a big, complex issue,
right.
But the education has to be at the foundation of that. And then when patients do develop a problem, we're going to get into a lot of detail about this, but as a clinician, do you have access to opioid use disorder treatment facilities? Do you have an addiction specialist? Do you have a psychologist in your practice or a counselor? That's going to be really important. And a lot of times physicians don't have that backup strategy, and we need that to help those patients that really need kind of emergent care that you really can't wait around for.
Well, I encourage everyone to visit the Opioid Education Hub on the web, www.cmeoutfitters.com, for a comprehensive list of resources, educational activities for providers, for patients, including the augmented reality program, which everyone agrees is particularly cool and well received. So CME Outfitters is now on YouTube. Check that out. Their activities and patient education there as well. So it's time to turn the program over to you, the viewers. What do you do with a patient who's been on low-dose opioids for 5 years? What do you suggest? What about removing the opioid but managing the chronic low back pain?
Yeah, so I think the question is a patient that sounds like they're on low-dose opioids for many years. They have chronic low back pain. I think there's a lot of options for the patient, and those are the patients we see in our pain center. First, really, what's the physical exam show? Is it facet pain? Is it radiculopathy? Is it myofascial pain? Getting a lot better understanding of what their underlying pain problem is. Doing the screening tools like we talked about, depression, anxiety. A lot of patients on opioids get an anxiolytic effect from the opioid. And so just getting a better understanding of what they're actually getting out of it. I think it's better not to rush to start decreasing their meds, but get a better assessment first, teach them other skills or get them into physical therapy, get their pain under better control, and then slowly reduce the opioid. If you do the opioid on the first visit without them having other tools, I think you're doomed for failure, unfortunately. So really doing the assessment, then considering slowly reducing the opioid, and maybe you'll find out that they can take half as much of the opioid or you can get them completely off. But really they need to have a better assessment and then learn some other tools before that.
Thanks. What about drug disposal education, Bill? And what should it be mandated every time an opioid is prescribed? What do you think the role of the individual physician, the patient, and the pharmacy might be?
Yeah,
I borrow your pen?
Personally, I think that an appropriate drug disposal mechanism should be provided with every prescription that's written at a pharmacy. Hopefully, we'll get there someday. I think the semi-annual take-back days at DEA are a good idea, and they're a beginning, but it has to go much more past that, much farther than even the regional or local take-backs. It's got to be very, very easy and convenient for the patient to be able to legitimately and safely dispose of the active ingredients in the prescription drug.
But it's doable.
It's absolutely
and I'll
doable.
comment again, like I said, in our state of Washington, we have new guidelines for primary care and perioperative pain, and we have specific time points where they have to give information about safe storage and disposal at the first script, even when they leave the hospital, but then it transitions from acute to subacute and subacute to chronic. So we're tying that in with the same times of when they're supposed to at least do a urine screen and check the PMP. So I think the education part for that has to be tied in, just like you do for when is the PMP appropriate to check the prescription monitoring program, as well as doing urine screens.
So this is a question for you. If you're getting a referral from a family physician who's had a patient under their care, and they have long-term back pain issues, how would you approach that?
And I assume that they're on opioids and they're being inherited. Again, the similar question before was to first do the assessment, and like the CDC said in their document in the last month in JAMA, that those patients on chronic opioids, you can try to reduce the dose, but do that in an empathetic way. But again, really getting a better understanding of what they're getting out of the pain medicine. So just do the screening like anything else, and also screen for depression, anxiety, sleep. What's the medicine doing? I like to walk a patient through the day. What time do you get up? What time do you take your medicine? What are you able to do?
Like
and that'll give you, it kind of gives you a good sense of, is this really helping them from a functional standpoint? Because you need to have that better understanding before you start telling a patient, we're going to reduce your dose, or I have to do this to your dose. If you don't understand what the patient's doing and why they're using the medicine and what the quote-unquote benefit could be, that's going to be a lot harder relationship with the patient. So again, the assessment, and then slowly reduce. And sometimes we hold the taper. We have patients on higher doses that we may hold the taper for a month, maybe take them down by 1 pill a month and get them down to lower doses, and then lower their risk for problems.
This is an interesting question, which how do you find an experienced doctor today for those individuals who suffer from both pain and addiction? And when I saw the question, I said, well, of course I remember Bill Jacobs at Medical College of Georgia, or we had at Florida, now in Jacksonville, Adrian Botner, actually double-boarded addiction and anesthesia pain, double-boarded addiction, or psychiatry and pain. Mm-hmm. But it seems to me that these are very few and far between. You maybe have to default to a clinic that's multidisciplinary. What would you recommend?
Well, I think I'm fortunate where our clinic is. We have an addiction specialist that's also pain boarded in our clinic, Greg Rudolph, so we can refer patients directly. I think most hospital systems, at least, as they move towards population health and taking management of the whole patient, have some addiction services within their system, but that's going to take time to catch up. But we get this question a lot. I think, can you identify 2 or 3 addiction specialists that right buprenorphine will help manage patients, get those to the right physician. A lot of our primary care doctors and pain physicians are getting certified to write buprenorphine, so the addiction specialist may start them on buprenorphine, and then the primary care can to take it over. So I think is the physician themselves interested in getting a waiver to do buprenorphine, and then having your own virtual group. Everyone thinks of addiction, right? But you also need to have access to psychology, relaxation therapist, and behavioral health. And so I think that's the key, is incorporating behavioral health and addiction medicine.
In your group, do you have like NPs and PAs caring for people with OUDs, or is it just MDs?
So our physician does a lot of the management, but we also have pain rehabilitation programs that incorporate physical therapy, psychology, relaxation training, and exercise. Those patients do what we call boot camps, where they're there 15 hours a week for 4 weeks. So we have a lot of patients that have a previous opioid use disorder. Their opioid use disorder is stable, but they still have a pain problem, and then we try to teach them other techniques to better control their pain. So we have different therapists, psychologists, physical and occupational therapists.
So this one's for you, Bill. It says, what is the focus of DEA in addressing addiction? Is the finger pointing on docs and pharma stopping?
Well, first of all, you have to remember that the Drug Enforcement Administration is about drug enforcement, and that's their primary mission. And but yet they still have a regulatory mission, which is conducted by the Diversion Control Division at DEA, and their responsibility is to properly manage the about 1.5 million registrants that happen to be here in the United States today. And DEA, the diversion units in the field divisions, rarely work solely by themselves. Wow. They always work
more questions
with their counterparts in the state and local levels. So any activity that they're going to take, any enforcement activity, is going to be the result of something that has come to their attention, more than likely from their counterparts, about a blip in prescription and something that's unusual. And I think that, as I've stated several times today, I think that DEA is beginning more of a collaboration mode with the discipline, and I think that's healthy, and I think it's going to continue.
Yeah, I would make a comment too, because I know in our own state and in other states there's different metrics, and unfortunately they're looking at opioid prescribing as a metric for physicians. And so we are seeing some physicians, this has nothing to do with the DEA, but some physicians are saying that the hospital systems are tracking how much they prescribe, and prescribing in itself may not necessarily mean they're doing a bad job. So a lot of the physician groups are a little bit worried about how metrics are used. And so that's one thing we're hopeful won't be a problem, because the physicians feel like they're being scrutinized, and they may be the only physician in a small town that's treating pain patients, and they don't want to be scrutinized. So I don't mean this is on the DEA, but I think the whole idea of metrics, we have to be careful with those, and how they're used, any kind of metric.
So someone asked about the study about Medicaid patients having trouble getting access, and basically you can find it on the web because it just was released as a press release yesterday from Penn State University, and it's just in the ASAM journal today, which basically was a secret shopper approach. They took people and said that that they were heroin addicts, and that they were looking for treatment, and saw how many BUP waivered physicians would agree to see them for a first appointment or to treat them. And that data was reported today. Someone asked about oral surgeons, and I know you have some insights on the role they might play. And
yeah.
Bill has some personal story.
Yeah, I think in our state of Washington, we have guidelines specifically for dentists and oral surgeons around limiting use of opioids for dental procedures. And just like we talked about with acute dental pain, many patients get an opioid and they may take 1 or 2 doses, and then the rest they keep in their medicine cabinet. So I think those same rules and risks with prescribing around dental procedures. But again, I think it will vary from state to state. how that's coming down. I mean, I think a lot of the opioid scripts that are written are just one-time scripts, and a lot of those are from dentists, emergency departments, and operating rooms, or post-operative pain management. So I would say an oral surgeon would have to use the same principles that we talked about.
Definitely.
And they probably would use high-dose NSAIDs and acetaminophen and hopefully get just as good a pain relief in some patients.
So I should say that I'm sorry that we won't be able to get to all the questions. We have so many questions, and I think in part it's because so many people have been taking part in this program and actively engaged. I thank you. We'll do the best we can. I'll answer some quickly. Are there any resources about lifting the bottom? That's been the best done in physician health programs and interventions with the boards of medicine in various states, and I'd refer you to an article by Lisa Merlo at the University of Florida, or Bob DuPont. The costs of programs like COAT, Jim Berry and West Virginia University had really limited resources and needed to develop a program that would not take resources from a state which didn't have them to spend in the first place. They weren't. So his program is built around use of community resources that exist already, NA and AA meetings, and then group meetings for MAT, and then urine tests. And you can find Jim Berry's interview and the COAT program on the CME Outfitters web site. What about the need for standing orders and changing standing orders in the ORs? Someone's a surgical nurse, and they say there's still so many standing orders.
Yeah, I think in our hospital, it's Swedish. I think we looked, there's 60, 70 different standing orders, some crazy number. Those orders are put in there for many years. They stay, and a lot of times clinicians forget about them. So that's been a big focus, is to try to limit those, standardize it, give a shorter number of pills. But she brings up a good point. I mean, the standard orders, I think, where there was just a number of pills that were prescribed out of convenience, so physicians wouldn't get called or nurse practitioners wouldn't get called, those contributed significantly to unused meds. So I would hope hospitals are looking at that and trying to standardize it. I know in our hospital system we've had to, because the pain rules were enacted, and so we've seen a significant reduction in the number of pills that are prescribed, which is probably a good outcome.
One. Is there a best choice for chronic muscle pain?
Chronic muscle pain is very tough, because the muscle relaxants are a very heterogeneous group. Tizanidine has an effect. Some of the other older ones, like Flexeril, are more of a tricyclic, so they cause sedation. So the muscle relaxers, I think, are a tough group. We really focus on strengthening those muscles, posture. A lot of that can contribute to chronic muscle pain.
So I thank everyone. On genetics, I say there's more to come, and hopefully we'll do a program like this on risk. Thank you, everybody. We appreciate you guys.
Thank you.
We appreciate Jessica. I know how busy everyone is, and really to dedicate yourself and come here to do this program. I can't thank you enough, and many of the viewers thank you. And some of these weren't even questions. They just said thank you, thank you. Appreciate everyone. I appreciate CME Outfitters for hosting this program, and I hope we can make a difference. Thank you.